Well, it looks like almost everyone that was in the waiting room is here now. So I'm going to go ahead and get started and just say welcome to today's webinar. Our webinar is on the topic of application of LSVT treatments post deep brain stimulation surgery, which we will also refer to as DBS throughout most of this webinar so that you know what that abbreviation is. And talking really about the idea of maximizing communication and mobility outcomes both before and after surgery if you are considering or have been through DBS surgery. This will be a great, just informative webinar on that topic for you. I am not the only presenter here today, but I will do a little introduction to start with. My name is Jenny Tecito, and I am a physical therapist. I'm also currently the Director of Communications and Innovation for LSVT Global. My background, though, is in spending more than 20 years in outpatient neurological rehabilitation as a physical therapist, where my expertise was in the area of Parkinson's and Parkinson-like disorders. So I'm going to kick things off today, and then I will be joined by my colleague, Beth Peterson, who is a speech-language pathologist, and she is one of our LSVT LOUD faculty and clinical experts, as well as helps work with us in organizing all of our webinars and a variety of other topics as well. So I will be talking about the movement or functional part of the slides that we have. Beth is going to focus a little more on the speech aspects of everything related to DBS, both pre and post. And so we're going to kind of do a little bit of flipping back and forth between slides as we have content that we are presenting. If you want more details about either one of us, this biography slide gives a whole bunch of information that I won't read to you right now, but if you're interested in learning more, please feel free to take a look at it in your handout. A few little disclosures is that we both have a financial and non-financial relationship with LSVT Global. Our non-financial relationship includes a preference for LSVT LOUD and LSVT BIG as treatment techniques. And as I said, we both work for LSVT Global. So a few logistics about the webinar, if you've not joined us for a webinar before, is we want all of your microphones muted for this presentation while we provide content so that we're not distracted by the background noise of where you might be joining us from. We will take some time towards the end, though, to answer questions. So a couple of ways you can ask questions is we can unmute your microphone at the end. You can ask a question live, or you can use the chat function throughout the webinar to type in a question that you have, and we will go ahead and answer those questions when we get to the end. So we won't answer them in the midst of it as much, although the faculty who's not speaking will kind of monitor it. So if there is an issue that we need to address right away, we will. As far as handouts go, Beth is going to go ahead and drop the handouts into the chat here in a little bit. So if you did not already get them via email, which you should have, but if you did not get them through email, she will put them in the chat so you can click on it and open it from there. After we're done today, there will be a short survey that we'll launch. We'd really appreciate it if you'd take the time to fill out the survey and answer any questions that we have in there. We really do use feedback that you give on helping decide on what our future webinars are going to look like. And since it's November and we're getting to the end of the year this year, we are actively working on planning our webinars for next year. So if you do have topics you're interested in, please drop those in the survey and let us know. If you are a clinician that is attending and asking or wondering about CE credits, we do not file for official CEU for these webinars, but you can try to do self-report. So here's some instructions here. If you are going to self-report, you're going to want to keep a copy of the handout. You're going to want to get your certificate that you've completed it, record the date, time, everything that you attended. And if you're watching this on demand, you will also need to complete the survey upon conclusion of the webinar. And there's detailed information on this slide on what you do from there. So licensing requirements do differ state by state. So your state may or may not authorize self-reported CEUs, but if they do, know that that's an option for you. We have just a few little learning objectives for you. So the first one is just to be able to leave this presentation and summarize the use of DBS in Parkinson's disease. Be able to kind of identify who's the good candidate for this and distinguish the rationale and for use of LSVT LOUD and LSVT BIG treatment, both before and after deep brain stimulation surgery. We're going to kick things off here with just a little bit of a poll. We're going to find out, we just want to know who's joining us. So are you someone with Parkinson's, a friend or a caregiver, family member? Are you a clinician who's certified? Are you a non-certified health professional or something else? So we're going to go ahead and launch this poll. Beth just launched it for us. If you can go ahead and just click your response to tell us a little bit about who you are. That'll help us as we go through talking on these slides today. And I'll give you just a little bit of time to be able to do that. Very good. Almost everyone has replied. We have a few that haven't, so I'll just give it a few more seconds here, give everyone a chance if they want to participate. Very good. Okay, and then let's go ahead and share those results. So we have a really nice mix of people that are here with us today. So we have a fair amount of people who are living with Parkinson's. We have some family, friends, caregivers of those people. We have some LSVT LOUD or LSVT BIG certified clinicians. And we have some non-certified health professionals and others. So we literally took up every category. That's fantastic. We'll make sure we'll speak to all of you as we go through the slides. We have one more poll that's coming up next, and I will have Beth go ahead and launch this next poll, where if you are a person with Parkinson's disease, have you ever had therapy? And what we're specifically wondering is, have you had LSVT LOUD or LSVT BIG therapy? Have you done both, or have you done neither? So go ahead and just take a moment to answer those if you are someone living with PD. And I should say with PD or related disorders, because we know that this treatment is effective for other related disorders as well. So please feel free to answer that question appropriately. Good. We'll give it about 10 more seconds here. So if anyone hasn't had a chance to answer. So far, it looks like we have a nice blend of all of the above. So, all right, let's go ahead and share those results. So it looks like we have some that have done LSVT LOUD, some that have done LSVT BIG, some that have done both, and some that have done neither. So good. Again, we cross all the areas, which is really great to see. We have representation from all different areas. Some of you may know very well what deep brain stimulation is. Some of you may come from a background of not knowing as much about what it is. So the goal of this webinar is not to educate you entirely on all the details of DBS, but we're going to do just a general outline about it for those that might be less familiar. Our focus will be more around the therapy piece of things, but we want to be able to introduce a little bit about it. So for those of you that are less familiar with what it is, DBS is a surgical procedure where they implant a medical device into the brain to be able to provide electrical stimulation to a targeted area in the brain. The goal is that they're going in and they're trying to stimulate those structures that help give us more control over some of those unwanted symptoms. Some of those unwanted symptoms that they might see some good results with using DBS could be things related to rigidity, bradykinesia, tremor. Tremor is usually helped quite a bit by DBS, and it also may be able to reduce some of the off times or dyskinesias. And if you know what dyskinesias is, that's great. If you don't, dyskinesias are those rhythmical movements that can be a side effect of high dosages of Parkinson's medications, specifically related to things like carbidopa, levodopa, where the more you take, the more you may have some issues with those dyskinesias. DBS is less effective when it comes to the area of balance, freezing of gait, or those non-motor symptoms. And the impact of the surgery on speech is complicated. Anyone who's been through the surgery might know that well. And we're going to talk about possible complications or issues that may arise with the speech motor system as a result of going through DBS surgery. What they're going to do with the surgery is they're going to go in and they're going to place those leads into the brain. There's two different areas that they can go in and place those leads related to the subthalamic nucleus or the globus pallidus. Placement can be done just on one side, or it can be done bilaterally. And then those electrodes are connected to what they refer to as something like a pacemaker, where those are put in your chest. And they look very much like a pacemaker might look for someone who's had one placed for their heart. But those electrodes are then put unilaterally or bilaterally in to control those leads that are put in. After everything's healed post-surgically, they work with a lot of programming to help optimize the functionality of those stimulators. So there's some, give and take that's going to go back and forth. They're going to play around with those settings and really try to find those optimal settings where your relief of symptoms are optimally affected, not affecting speech too much, and really trying to help control those symptoms, which was your goal of going through the surgery. Now, there's pretty stringent guidelines to be able to go through surgery for DBS. So your neurosurgeon or doctor will send you through a lot of different things first to make sure that you are a good candidate. Some of the things that they look for is that you truly have a diagnosis of idiopathic Parkinson's disease, that you have responded really well to the use of levodopa with substantial motor disability, meaning they don't typically do the surgery early in the diagnosis. It is brain surgery. There are risks associated with it. So typically they're looking for someone who has had symptoms, has responded well to levodopa, but those symptoms have progressed, maybe starting to think about it's maybe time to talk about surgery. They want to make sure that there isn't issues or significant issues related to dementia or neuropsychiatric problems. They're looking to make sure that you're safe to go through surgery. So you're probably going to have to go through screenings with your general practitioner, things like that, to make sure that your medical risk level is low. And looking at your individual symptoms, and are those individual symptoms things that can be improved with this surgery, and what should the target of the surgery be? So which direction should they go with those leads and where they place them in the brain, and some specific organization of where they want those leads to be. Know that this option of going through neurosurgical surgery of DBS is one of your options for treating Parkinson's disease. And we kind of put them all on an even playing field, right? There's a time for the pharmacological intervention, which is your medications. There's time for the voice and body exercise. And then there also may be a time where that neurosurgical intervention becomes a piece of the game, or a thing you want to start looking at to see, would I be a good candidate for that being added to my medical picture? Realize that this whole process is a part of a multidisciplinary team. So allied health should really be a part of that team, both before and after surgery. You can see people that might be listed as a part of your medical team here, as well as those who might be a part of your allied team, such as your speech, physical, and occupational therapists, neuropsychological, social worker, nutritionist, all the people that might be involved in making sure that if you do go through this surgery, you are the right candidate, and that you have optimal support both before and after. So we're going to guide kind of the rest of our talk in looking at it as before and after. And before DBS surgery is where we will start. So some things to consider with LSVT LOUD or LSVT BIG before surgery is we do feel it is very beneficial to have gone through treatment with your physical, occupational, or speech therapist prior to having the surgery. From someone with over 20 years of clinical practice in this specialty area of Parkinson's, I would say my goal always is to try to optimize your functional level prior to surgery. So let's get you in the best physical condition, best ability level before we go down that road of surgery. Your path afterwards is just going to be easier if you're already in a good position physically with your functional abilities. Beth would tell you the same with your voice, that maximizing and optimizing through voice treatment with LSVT Loud would be ideal before considering surgery. How much is possible with therapy alone? How many gains can we make? And let's get you calibrated to that best ability level before considering going through surgery and going through that process. It also helps us to establish a baseline for voice and activity and functional level before surgery. So we know what therapy itself, therapy and medications can produce, and then be able to look at, hey, what did the surgical option add to that picture? And how can we fine tune things? So specifically with LSVT BIG before DBS, I would recommend all of my clients come and see me and do therapy, whether it's their first time doing LSVT BIG or if they're coming back in simply for a tune-up before surgery. So those of you that have had the treatment before, that initial round of treatment, whether you're doing LSVT Loud or LSVT BIG, is 4 times a week for 4 weeks. We treat you, we maximize function, all of those things. If you've been through that before and it's been a year or it's been longer or shorter and you're preparing to go in for surgery, we would love to see you just for a tune-up, which might just be a few sessions before you go into surgery, just to really maximize and optimize things, help with a little education on what to expect after, and talk about how we want to bring you back into therapy after to maximize those motor function changes that you might be experiencing post-surgery. We want to stay focused on that increased amplitude, collect those outcomes, and be able to compare pre-surgery and post-surgery, what your balance assessments, falls assessments, all of those functional assessments look like so that we know where we can work to maximize. We want to stay in touch with that interdisciplinary team. We want to be aware of any changes you're noticing outside of those functional changes, such as mood, speech, and cognition. And we want to be able to alert that team with any concerns. So any of you have been through LSVT BIG, know you get to know your therapist pretty well. They might actually know you a little better than your doctor because they spend a lot of time with you. So knowing your personality, your ability level can be really a great asset to the allied medical team, because we can go back and say, hey, he wasn't having this issue before. We're noticing it now. Is there anything you can do with that fine tuning of that DBS to help resolve this issue? So we can be another partner in that medical team to help provide feedback. And then Beth's going to talk a little bit about the LSVT Loud side of things.
All right, great. Thank you, Jenny. And yeah, I'll go ahead and jump into LSVT Loud and thinking about how we might be treating speech symptoms prior to DBS surgery. So just as Jenny mentioned, with LSVT Loud, we would also recommend getting treatment prior to DBS to really optimize where you are, and then we could make adjustments with that later on as needed. But either way, before surgery, we would want to evaluate the speech pre-surgery. We would do that with a high quality recording. So we have that as a reference point, as a baseline. In some cases, clients may also consider that to use later for voice banking. So it's something that we want to have a record of, and so that we can refer back to that as we continue to see you. We also want to make sure we're talking to our clients about the possibility of speech changes as a result of DBS, what they may look like, what we would want to help you do with those changes, how we're going to monitor changes. So it's important to have, again, that speech therapist on your team so that you're aware of things that may occur, so that we can help you down that road and what it might look like, and what the plan would be to help optimize communication. So those knowledge and options can really provide some of that empowerment of speech and motor control before surgery. So again, so you know what to expect and what can occur. And then with that, I'm also going to introduce Dr. Alina Tripoliti, and this is a video interview that we did. And this is just a short clip that you'll hear from her. And she's really the world expert in DBS and speech. And she's an honorary associate professor at the Institute of Neurology at the University of College in London, and also a clinical specialist in speech language therapist and movement disorders in Queen Square, London. And she's going to specifically in this clip talk about pre-treating with LSVT Loud before DBS, and why we may want to consider that.
I'd like you to share your experiences and your work with treating patients with behavioral treatment prior to the surgery.
Assessing patients before is paramount, and after, with proper recordings, because it is like, you know, a photograph. You've got to keep a record of how voice is. What we've started doing in our team, and it's part of how you see a patient's journey. Since we identified that speech it does deteriorate with DBS, we considered it's the best way is to offer therapy before, because not just you don't just empower the patient, you give them a tool to control the voice before surgery. You also it's a decent way, the decent thing to do when you tell them your speech might deteriorate. You don't just leave them to wait for it to happen. You give them a tool to be able to deal with that after. Of all the patients we've treated before surgery, we've had 10% coming back after surgery with, you know, big issues to do with their speech. The majority can cope with the small fluctuations of speech and voice changes that happen post-DBS because they have their LSVT before. The LSVT before needs to happen, in my opinion, for every patient who goes through DBS. And whether they think they have an issue with their speech or not, it's not just to you're not telling them you will have a speech problem, you better have it. It's good for them whether they have a speech problem after or not. You know, it's what should happen anyway. So the key is that after surgery they can deal with these little bits of fluctuations every time they change something in the stimulation or the medication. They're ready, and you don't need to do the whole LSVT after. You can just go for a week or 2 weeks and tune them up, and they're ready. They don't need that 4 weeks. And then they know themselves how tiredness can affect them, how the day's medication affects them. So yes, I think it's the only way forwards.
All right, so I agree with what she's saying there. So the idea of pre-treating and that idea of having tools in your toolkit. So by pre-treating with LSVT LOUD prior to DBS, we've optimized the communication where the patient is, and then we've given them the tools that they need so that they can, make adjustments as needed post-DBS, because they know, a little bit more about how to control their voice based on what we've done in treatment. So a nice idea on being able to do LSVT LOUD prior to DBS. And we'll shift gears a little bit, and Jenny will introduce what it might look like doing LSVT LOUD and LSVT BIG after DBS.
Perfect. Thanks, Beth. So thinking then, now you've had surgery or your patient has been through surgery, and what happens after? What do we need to do after? So we had a great introduction there as to what Alina would recommend, and why you'd come back in for that tune-up to really assess that functional ability. But here's some things is we want to look at addressing any persistent issues with communication, walking, balance, or activities of daily living that might have happened. We want to work on assisting and retraining that appropriate level of motor control, both for voice and movement. So sometimes after surgery related to movement can actually get too big, which can affect your fall risk, balance ability. So really looking at it from that perspective of, do we need to do some retraining of that motor system to be able to recognize what is normal and how we find normal again? And then maximizing function really after that surgery and recalibrating back to that most optimal level of function related to voice and movement. So what can change after DBS? Well, there has been some things published that have looked at what is the possible changes that we might see. One great thing is we might see increased freedom of movement, right? I mean, after living in a body that has become hypokinetic and bradykinetic, which is those slow and small movements, being able to finally have that ability to move more freely is wonderful. But when those movements are more free, do you have the motor control to control it? So that next bullet point then on movements can get too big. How do we learn that motor control to control that new pattern? Risk for falls can also be increased as a result. So when I think about this, I always explain this to my clients on, imagine taking an older car where it hasn't been started in a long time, and all of a sudden you power up that engine, you lube up the engine, you give it, an oil change, you do all these great things to it, and you turn it on, and all of a sudden this engine has all this power that it hasn't had for a long time. Do you get in the car and put the pedal to the metal and go? That's dangerous, right? So it's almost a matter of learning, hey, here's my new ability levels that this surgery has provided me. And then how do I learn the motor control to control that to optimize my function? And as we mentioned, and that Beth will talk more about, we do know that speech can be negatively affected by this surgery. And how can we address any of those negative effects that have happened? Also, if there's any issues related to cognitive decline with verbal fluency, processing speed, memory, things like that, we want to be able to talk about those things and see what we can do to help. Know that it is possible that you may, if you're a person living with Parkinson's, you may be able to reduce your medications post-surgery, decrease your levels of Sinemet, carbidopa, levodopa, which can help to decrease dyskinesias if you were experiencing those before. But that is not your therapist's role to help guide you in that process. So that will be with you and your physician, determining if you are appropriate to be able to try to step back a little bit on some of those medications. What things are not going to change post-surgery? Well, we don't really see a lot of changes with those sensory awareness issues that we address through LSVT BIG and LSVT LOUD, where if my voice is too small or my movement's too small, why don't I realize it and change it? So that sensory piece of awareness, we still need to address. DBS does not stop the progression of the disease. We are not likely to see issues with protective balance responses. We may not see changes with walking or freezing issues. Posture may not change. And we also see that if there is gait improvement, that can start to decline 5 years after surgery with the subthalamic nucleus version of the DBS. So this is where your therapist is really critical, is we want to try to maintain as many outcomes and benefits that you've gotten from the surgery and try to maximize those for the long haul, right? So using your therapist to help supplement what you've had happen with surgery is really important. As far as fear of falls and falls risk, there was this really interesting survey that came out by the Parkinson's Alliance, which currently the PMD Alliance now is holding all of these surveys for them because the Parkinson's Alliance closed their doors this last year. However, this study was really interesting. So it was a survey of people that have had the DBS surgery and those that have not. So 334 people that had had surgery, 819 that had not. All 50 states were represented, and a huge variety of the age groups were represented as well. What they found, which was really interesting, that after deep brain stimulation surgery, there often was an increased fear of falls. There was actually a 2.5 times the risk of falling for those that had had DBS versus those that had not. There was a greater frequency of falls with their increased time with having had Parkinson's. And they self-reported more difficulty with mobility, speech, and stigma. So you might be wondering why, right? Well, we did introduce that this may not always help with gait or freezing or issues like that. But again, if you think back to my car analogy, right, is you've stuck the key in the ignition and turned movement on, and suddenly there's all this freedom to move without the lack of the ability to control it and know how to safely do it. So I really do think that post-surgery, as far as LSVT BIG goes, and seeing your physical or occupational therapist is critical, that you need to come in, learn that motor control, learn how to control the gains that you've received, and be able to maximize your outcome, which would explain the outcomes of this surgery and why, or the survey, and why people were noticing more issues with falls and balance potentially. And off to Beth.
All right, thank you. I'll go ahead and talk about some of the speech characteristics that research is showing and we're seeing clinically post-DBS. So DBS in the basal ganglia has been shown to have a negative impact on speech with either moderate to severe speech deterioration reported. So we are definitely seeing some changes in speech. While some individual components of speech may improve, things such as loudness, oral force control of the tongue, or overall speech intelligibility is likely not improved through DBS. And then speech problems, the term that we're using and we see in Parkinson's is dysarthria. So dysarthric speech is reported after DBS in the subthalamic nucleus between 5 to 61% of individuals. And depending on the placement, speech function does seem to be less compromised in the globus pallidus interna than in the subthalamic nucleus, but further study is needed on that. So that would be a decision with the neurosurgery team, based on, where that surgery and where those electrodes would be placed, depending on what your needs and desires are for the surgery. I'm going to show you now a couple of audio clips, and this is when the electrode placement was either placed more medially versus laterally in the subthalamic nucleus, and there's definitely a different speech profile for this. So, and the medial placement, we're seeing more strained or tight and kind of continuous phonation, so more of kind of like a strangled voice quality that you might hear, more inaccurate articulation, more breathing insufficiency or the perception of that, and then less responsive to behavioral therapy. So Jenny, if you want to go ahead and play that audio sample.
I have freaking Lucy, Daniel, Jonathan, not necessarily in that order.
What order do you have them?
Daniel's the first, only say 2. Jonathan is the second, more now. 9, and then we got Lucy,
And how many
the talent.
Nearly 36.
Yeah, that's right. Yeah.
Great.
All right, and then we'll listen to the lateral profile. And so with this, we hear a little bit more monotone or flat intonation, so not a lot of variability in that pitch, a faster rate of speech, and then we're seeing reduced movement of the lips and tongue. This is a little more hypokinetic and responds well to LSVT loud. But with these individuals, there may be some fatigue and some apathy. So as clinicians, just working with that fatigue, acknowledging it, throughout the treatment sessions. So can you go ahead and play that lateral speech profile?
Timmy's moving up to middle school in September. Luke is 13, enjoys playing football. Everything about football, collecting football cards, reading football magazines, and my daughter is the same. She plays football for Bedford Ladies, girls under 10s.
So you can probably hear, a lot of differences between those two speech samples. So through treatment, your speech clinician would be working with you very specifically on your needs and modeling and shaping the voice as needed, because it can be very different from patient to patient depending on the placement of the electrodes. So just considering that as clinicians too, again, just really individualizing treatment to the patients that we're working with. And this is very important. So there's some research out there looking at speech characteristics post-DBS from the patient's perspective. So what are they noticing? What's changed in their own voice and speech? So there were significant differences in the severity of perceived speech disturbance between a group that had undergone DBS versus those who had not. More severe symptoms of speech changes were reported in that DBS group, and then more symptom interference with social interactions. So those daily, kind of daily experiences that were relating to functional, physical, and emotional issues of a voice disorder. So just seeing how those voice and speech changes really did affect overall social interactions and, functional daily living in terms of using the voice. Low volume was the most common speech symptom, and then DBS had the greatest adverse impact on slurred speech. So whereas with idiopathic Parkinson's, slurred speech is not usually one of the most prominent features, but we are seeing that more with DBS surgery. And there's not a whole lot of research on DBS and speech treatment. I'm just going to show you a couple studies that are out there, and they do focus on LSVT loud, but just in general, LSVT loud or not, there's not a lot of speech treatment in DBS studies that are available. So it's something that we need more of to really have a better understanding of how individuals post-DBS will respond to speech therapy and what might be the appropriate targets and techniques to use. So I'll show you a couple studies looking at LSVT loud post-DBS. And the first one we'll see, so this was a smaller study. There were 4 individuals per group. We had a group of those with Parkinson's that had undergone DBS, a group with Parkinson's that did not have DBS, and then Parkinson's that was not treated. And so what we were seeing in both the treated groups, so DBS and non-DBS, we can see in these first 2 bar graphs, and we're looking at changes in vocal loudness, or what we call decibels of sound pressure level. So blue is pre-treatment, orange is post, and the red is 6 months follow-up. And so we see that some nice changes from pre to post for both DBS and non-DBS, and those changes were maintained out to that 6-month mark. So some significant differences from pre to post and continued at follow-up. So that's really promising. And then if you compare it to this untreated group that pretty much stayed the same from pre to post out to that 6-month mark. So in that same amount of time, nothing had really changed in terms of vocal loudness. Now, even though we're seeing some great results there in vocal loudness, the clinicians and researchers were noticing some kind of qualitative differences between these groups. And for those that had DBS, it was more difficult to establish a target voice quality. So by that, I mean we really focus on loudness with good quality when we're treating. And for those that had undergone DBS, it took more for the clinician to work with the client to really shape and get that optimal voice quality. There was more hoarse voice quality, more persistent slurring and impaired tongue control, which again were not as typical and for those that had not undergone DBS, and more difficult to generalize outside of the treatment room. So you may hear us talk about calibrating and the importance of that. And really what calibrating means is we're calibrating our patients and clients that we work with on this effort level and what it should feel like so that they can use the same effort level and know what it should feel like outside of treatment. So there was a little bit more difficulty in terms of the speech pathologist getting that effort level and helping the clients realize what it should feel like and transferring that outside of the treatment room. The next study was done by Alina Tripoliti, so the woman that you saw earlier in the interview clip. And so this was also looking at a group who had undergone DBS and a group that had not. And this was a little bit larger, so she had 20 participants per group, looking at pre, post, and follow-up, and also measuring decibels of sound pressure level or vocal loudness across. We see a reading task on the left and a monologue, so a conversational speech topic on the right. And so we are seeing some improvements in the DBS group, but not significant from pre to post and not really maintained out to that follow-up when compared to the group that did not undergo DBS. So that's at their reading level, and even more so in the monologue, didn't see an improvement from pre to post in a group as a whole when compared to the group that had not done DBS. And so, it's kind of inconsistent, and what the results were showing us was that there was not a statistically significant improvement in vocal loudness in that DBS group. Now, within the group, there was some variable response. So some were responding well to LSVT loud, and there were some trends for improvement in vocal loudness, but it wasn't, necessarily the group as a whole, and this is the therapy, and this is how you should do it, and this will definitely work. So more work needs to be done in this area to, again, see what would be the best type of therapy to do and how therapy should be done with those who have undergone DBS. And Jen, if you want to go ahead and talk about how you can maximize LSVT big outcomes after DBS.
Yeah, absolutely. So with LSVT big related to movement and functional practice, our goal after DBS is to really work with you on that modeling and shaping that we talk about as treatment terms with doing LSVT big. So we want to make sure that we're getting your exercises, your functional movements, your walking, your everything to be graded at an appropriate movement level. What I've clinically seen sometimes is that the movements become too big. Maybe people will move what we call back into extension. So going back far too far than they should. So finding that midline, finding that neutral, and finding the motor control that is needed to be able to move as normally as possible, or as like we like to say, before Parkinson's gotcha kind of thing. Try to get back to that level of ability that would have been more typical of your movement pattern. So using your therapist to help guide you to that appropriate size of movement, to feel what that appropriate size of movement feels like, and then be able to continue to replicate that both in therapy and outside of therapy. So that idea of stabilizing and calibrating is, did you feel that effort? That's the same amount of effort that I want you to use when you're walking, when you're out in the community, and help relearn that new internal cueing now post-surgery for what that more typical or more normal movement pattern might look like and what it might feel like, so that you can use that in your day-to-day life. And I'll go back to Beth.
All right, thanks. So in terms of LSVT LOUD and thinking about how we can maximize some of these speech outcomes post-DBS, so you see here repetition is really important. So you'll do multiple repetitions with your client or as the client of the different exercises we do to really kind of solidify that loud voice, that feeling of loud, what it should sound like. We're really making sure that we're acknowledging fatigue within treatment sessions. So even as simple as validating, yes, I know this is hard work. Let's take a quick break and then we'll jump back into it. It might be for individuals post-DBS, we give them longer rest periods in between repetitions. We're not changing anything in our LSVT LOUD protocol, but more so just making sure that we're responsive to the needs of our clients. With LSVT LOUD, we typically progress from a word level all the way into continuous conversation using this newly trained loud voice. Post-DBS, we might be working with clients more persisting at that phrase or sentence level as opposed to moving on so much to loudness in full conversation. At least within the 4 weeks. So it might be that we have to extend a little bit beyond the 4 weeks to get to that end result. We're bombarding with functional and salient calibration activities and feedback. So we're making sure the activities that we're doing in treatment are really meaningful and functional so that individuals can have the most possible or optimized functional communication outside of treatment. And because we've learned that within the treatment session. And so we want that to carry over outside. We may use the family and support system even more for some of that carryover, again, to make sure that we're working on exercises and activities that are functional to the client, and also getting feedback from that support network to see, how is your loved one doing outside of treatment? Are they using their louder voice? Is it easy to understand them? So that you can really tailor treatment to what would be the most functional for them, again, to optimize their communication. We really keep the focus simple. So we focus on loudness, even if, as the client, maybe your target is, I'm worried about my slurred speech or my articulation or my rate. The clinician will recognize this, and we train them on recognizing that. And through treatment, by the client just focusing on loudness, we're able to address those other characteristics as well. So simply by getting loud and modeling loudness, we can also work on, articulation, rate, breath support, things like that. But the clinician will focus just on loudness for the client so that there's, a simple focus. We're not diffusing the focus with other areas, and that can really help optimize those treatment results. I mentioned you may consider adding sessions. So Typically, LSVT Loud is 4 days a week for 4 weeks. When we get to that 4th week, if we find that you think we could really calibrate or really get to that next level if we just had one more week of treatment, then we certainly say that clinicians can add another week of treatment to, again, try to optimize those results. So what we don't want to do is go into treatment on day one thinking, okay, I've got 5 or 6 weeks with this client, I can kind of spread it out a little more, but rather we're going to work our clients to those high effort levels through those 4 weeks of treatment. And then again, once we get to that end of the 4th week, if we think if I just had a few more sessions, I think I could really get this voice to a more optimal level, then we'll go ahead and add in those sessions. And with those sessions, we might also add another cue. So I'll show you a video soon where one of our colleagues, Angela, is working with the client, and she adds in the cue loud and fast because she had optimized that loudness and it was great, but the client was still a little bit slow in her rate and she wanted to improve that. So that simple cue, loud and fast, and modeling a little bit loud and fast really helped that client get to that next level. You might also consider technology or devices as a supplement. So we always want to and advocate for functional oral communication to the best level that we can get to our clients. If you've kind of tried all those options, use all the tools in the toolkit, and you're not able to get the client where they want to in terms of conversation, you might consider some other types of speech aids or augmentative communication devices that could also assist with that. And then I'll also talk in a couple slides about how you might alter environmental conditions, again, to make kind of optimal conditions for both voice and movement. For both LSVT Big and LSVT Loud, for those follow-up sessions, your clinician should be checking in more often. So we would say about, every 2 or 3 months. And sometimes a check-in is simply just a phone call. How are you doing? Do you sound good? Are you moving well? All right, great. We'll check in again in a few months. Other times we'll actually bring clients back in for tune-up sessions. And so you'll be coming in more often for those than other clients who have not undergone DBS. And so just, again, more frequent check-ins and then checking in sooner than other clients. We also have some maintenance groups, Loud for Life and Big for Life, that can be great support systems. These are groups that are people who have gone through LSVT Loud or LSVT Big, and so they've all gone through the individual treatment, and now they come together usually once a week, led by an LSVT Loud or LSVT Big trained clinician, and they take them through the exercises. It can be really a fun and motivating social way to keep up with the practice. And so you can see if those are available in your area, and you can find that on our website under Find a Clinician. We also have options available that Jenny and I actually both lead virtual classes too. So if you're interested in that, we'd love to have you join a virtual class. So those can be some nice tools to keep you practicing your voice, again, in a really motivating and encouraging environment. And what I want to show you next.
Tell me about your professional voice.
Oh, sorry, this is Lucy. And so what we're going to see here is Lucy was diagnosed young onset Parkinson's, and she was treated early on in the course of her disease, and then later on decided to get DBS. And so we'll see her pre and post LSVT Loud before DBS, and then we'll see her again. She was treated post DBS as well. So we'll go ahead and kind of see her whole journey with DBS and LSVT Loud.
Tell me about your professional voice use and what you've done.
I should have brought in a tape today. I did a demo tape of voiceover work just a few months ago here in Denver. I had it produced. I have gotten a power under my voice that feels real comfortable, and I feel like my voice is alive again.
I knew the chance of slurred speech was great.
Okay.
But I didn't realize that that's what it was going to sound like.
Okay. So really be thinking loud and fast when you're ready.
Oh, my little kitten, how are you? Are you hungry? Hello.
What do you think?
I think that that's the best I've heard my voice in years.
All right, so that was an example. That last part of the clip, Angela, the clinician, had added another week. So she decided, I've got Lucy, she's doing great, but I think if I just had a little more time, I could really, again, kind of optimize that communication. She added an additional week and then also added that cue of loud and fast. And you can see that made a difference. Lucy was very easy to understand when she could really focus on that cue. And then next, I'm just going to talk a little bit about tips for improving the communication and movement by altering the environment. So we really want to work with family members and support systems in carryover cues. And so we would train the support system on what would be appropriate cueing and maybe times that it would be appropriate to cue. Specifically for LSVT loud, it's not that I want, a caregiver or loved one to cue be loud every time, all the time that you talk in any type of environment. But I would, I might say we have this list of functional phrases. Anytime your loved one is saying this phrase, they should be in their loud voice. If they're not, here's the cue that I use in therapy. So we would train caregivers and the support network on what would be appropriate cueing in the home environment to help with that carryover. We want to try to reduce distractibility and background noise. So, turning off the TV if you're not watching it. Just in general, trying to think about your surroundings and trying to optimize some of those settings, making sure it's a safe area to walk and move around. So just being more aware of again, the surroundings. Being patient. So, as a clinician and family members and caregivers, just allowing time for some of that potential delayed processing and having patience and when we're communicating and working with those individuals. If for loud and communication, it can be helpful to define the topic of discussion that you're focusing on. So, okay, next we're going to talk about, why we should take this vacation next month. And so it can help with that, cognitive shift there. And then asking yes or no questions to clarify as needed. And then just keeping it simple. So again, we focus on loudness. Big focuses on bigness, so keeping that focus simple and so that it can transfer and carry over into daily living. And we say that everyone should have a chance. So we say don't discount successful treatment options just because you're seeing or noticing that your speech or movement is severe or complex, or you as the clinician, if you're seeing this, don't discount them as a good candidate. You can always try as a clinician to do stimulability testing in a week, so a trial week of treatment to see if LSVT loud or LSVT big may appropriate. So I always say if you like anything that you hear in your stimulability testing session, so that's when we're trying to see, if we model loudness and cue for loudness, can they get louder? Does their communication improve? And the same thing for working with LSVT big. If you're doing those stimulability testing sessions and you're seeing good results in movement, then we say go ahead and try a week-long trial of treatment. If you like what you see there, then go ahead and try the full course of treatment. And you can really be amazed at some of the outcomes of your clients, or if you're the one undergoing DBS, the changes that you can make through these treatment protocols. For speech, we say that functional oral communication. And then for big, that functional movement of any kind can dramatically improve quality of life, even if we do still have to have some supplementation or external cueing from the environment. But just allowing for more participation and activities of daily living can make a huge impact. And that's what we want to be doing, and that's what we're here for. And just some considerations. So it's preferable for the client to be stable in their DBS settings prior to treatment. We understand that this can be, a fluctuating time. It's not going to happen overnight. We were talking to a gentleman before this webinar about, it could take months or years to be stable. So you don't have to wait forever until it's absolutely perfect, but just the idea of, wanting to be comfortable with the new procedure and what the settings are like and what you're feeling like now, and kind of just getting a little more stable and comfortable where you are. Balance and gait deficits may persist despite DBS or may be increased. You'll continue to need repetition to learn the appropriate amplitude or motor control, whether it's an LSVT big or LSVT loud. So we would do a lot of repetitions to get used to that. There may still be some freezing post-DBS, so we would include some freezing triggers in treatment. Motivation, mood, and cognition should be monitored, and adaptation should be made as necessary by the clinician to really personalize that feedback in the treatment sessions. And in some cases, an individual's expectations may not have been fully met through the DBS process. And if we go back to those beginning slides, we as therapists should be part of those conversations with the patient and the neurosurgery team to talk about what some of the effects can be for voice and movement, so that clients are aware of what can change, so that they're not, totally thrown off by those changes after treatment. And then just having speech, PT, and OT should stay in communication with the DBS team regarding any observations during treatment and shared by the client. So again, just that idea of being part of that team, having those allied health professionals be there can really help those clients. So in summary, some of these speech and motor changes post-DBS can be complex, and they can be common as well. The placement of the electrodes can differentially impact speech, so just being aware of that, talking to the neurosurgery team about that pre-surgery assessment, educating clients, and some of those voice and movement recordings, and treatment for speech, PT, and OT are all warranted and encouraged. There's multiple techniques that clinicians can use to maximize these treatment approaches, and we do specific webinars for LSVT Loud and LSVT Big trained clinicians to help them really, learn more about some specific techniques that can be used. And some clients may need more treatment sessions beyond just our typical 16 sessions to maximize their communication or movement. There's a great need for research in these areas, so we would love to collaborate with anyone who's interested in doing research in this, and really just that idea that everyone should have a chance. So those are kind of our main summary points and take-home points from the webinar here today. We have a list of some resources that might be helpful to you if you're interested in learning more from some of the Parkinson's organizations, and then some specific to DBS as well. And if you do have questions, I've seen a few come in. You can type them in the chat box on your control panel. You can raise your hand or click on the hand icon and we can unmute your microphone, or you can unmute it. We'll call your name and you can unmute it. And if you think of questions later, you can also always email us. So it's info@lsvtglobal.com, and we're happy to take those questions later as well. So Jenny,
I'm gonna interject just for a minute, because we actually are really lucky to have someone in our webinar today who is actually one of our volunteers for our LSVT courses that we teach. He's also an ambassador for the Parkinson's Foundation and a fellow DBS person who's been through it before. So Dan, are you there? Can you unmute your microphone and say hello?
Yes, can you hear me now?
We can.
Okay.
So I asked Dan if I could invite him just to share a little bit about his personal experience with going through DBS. And can you just remind us, Dan, or remind me, when did you go through your surgery? How long ago was it?
Which one?
Well, tell us about both.
Yes, I've had both. That was a joke. I had a STN surgery, DBS surgery in 2013. Unfortunately, the surgery locations back then was it's gotten a lot better. So the surgery, everything I'm going to say is kind of out of date now. We were not as good at hitting the right target. We were off by 2 millimeters out of a 5 millimeter target, and I had a lot of crosstalk and a lot of speech issues. And I could talk better by turning my device off than with it on. So it was a huge impact on me. And for me, it was the wrong target, because you need to know what your expectations are with DBS. What symptoms are you trying to address, and make sure that you're hitting the right target for those. In my case, since I'm not tremor dominant, the right target for me was the GPI location, and that has less likely to impact your speech and less likely to impact your cognitive functions. And for me, I had a set of new braces fixed for my legs, all set up, ready to go. And I walked in, had the GPI surgery, and my gait issues completely gone. I've never used the braces. So my second surgery was in 2017. We pulled the whole thing out, unfortunately, put a whole new system in. So the two main things that have changed on DBS over the last few years is one is they are much better at hitting the right target. So don't let anything you see from us now scare you away. If I had to do it again, I'd do it again. Secondly, is they now have the ability to direct the electrical stimulation to the right spot with the leads that are in your brain. So it used to be the shape of a donut, and they could only make it bigger or hotter, but they couldn't direct it. Now, if they miss by 2 millimeters, they can actually steer the current towards the target and help address some of those issues. So it's a lot better now in both those respects. Go ahead.
I was just going to say, Dan, and then can you just shed a little light on how therapy with, doing speech or voice or movement therapy really helped you kind of hone in and get the most out of the results that you wanted, and was complementary to having the DBS surgery?
Yes, thank you. So DBS allows me to exercise better, which means I'm more likely to have good effects of exercise, and LSVT BIG is certainly a part of that. So I work with a group of guys in a boxing class, and I've seen guys get better. Now, that doesn't mean their Parkinson's has changed, doesn't mean their symptoms are gone away, but their symptoms are reduced because they've had training and because they've been through LSVT BIG. They can exercise better and get more out of it. And I've got guys that are better functionally at boxing, at lacrosse, at hockey, at lots of different sports, better than they were 5 years ago.
And then what did you notice some effects to your speech, and what have you found to be helpful with your speech?
So my speech results were better a year or two afterwards than they were before, just as from the training and from the change in the locations of my DBS surgery. But once again, STN location is very good if you're tremor dominant and that's your main issue you're trying to address. And if your second main issue is trying to reduce your medication, then STN is a great location, and that's why it's the traditional target of most surgeons. GPI is a newer use and has less likely to reduce my medications. I have not been able to reduce my medications at all, and I'm just now falling off mine. So you're seeing me in my off state right this second. But less likely to affect, doesn't have as much effect on tremor as it does. And on falls, we used to say all DBS did was allow people to fall faster, because they could move faster, so therefore they fell faster. Our number one rule is do not fall. And whatever, I saw a question a minute ago, whatever it takes to help you not fall will give you more confidence and help you function better. So one of my guys who was very frail used his cane for a few months, even brought it into class with him, and then eventually was able to stop bringing his cane as he got better and stronger and less afraid of falling or tripping.
That's fantastic, Dan. I think we could sit and talk to you all day. You have such great information to share, but in the effort of time, I know we are at our time limit for our webinar today. We will stay on and just answer a couple of these questions that popped in real quick. If you do need to leave us, though, you certainly can do that. I'll just take the first one and respond to Phyllis about your DBS and how your speech has changed. I would say, yeah, I would reach out to your doctor and ask for a referral to see a speech therapist, preferably for LSVT LOUD if you've not had LSVT LOUD before, but trying LSVT LOUD and seeing what they can do to help work on your speech now that you are post-DBS, and see if that helps. And then, Beth, how do you find out about the online, I think, Loud for Life class is what Amy was asking about?
Yeah, so as I mentioned, with LSVT Global, we do host some virtual online Loud for Life classes. And so you can do that. So if you go to our website, and maybe I could drop the link in there. But if you go to our website, and sorry, Jenny, I'm blanking on exactly where they can go with it. So you might actually be better in addressing this.
I'll put it in. So the virtual platform that we have is called lsvtforlife.com, where if you are a person that has had LSVT LOUD treatment, you can find Loud for Life or Big for Life classes. There is a free 30-day trial with that. I know we at least have one other person on this webinar that's a part of those classes that we love to see her face all the time. And the other question is, if you are a clinician and you are looking to get trained in how to lead your own group classes, you can go to our main website, which is lsvtglobal.com, and I'll put that in there. And then go in the store, you are going to look for the course that's called Loud for Life or Big for Life. Now that's for clinicians if they're interested in taking that training. Let's see, do we have anything else? How do you determine the optimum timing for surgery? Do you want to take that one, Beth?
Yeah, so I mean, it would definitely be a conversation that you would have with your neurologist. But basically, when you're current on your medications, stable on your medications, that's a good indication. That's a good way to think about when surgery might be a possibility. I would say it's definitely a conversation to have with your neurologist to see if you would be a good candidate and when they might recommend doing that. And then, Dan had some really nice insight onto, knowing what your, kind of what your goals are with that therapy. So what's most affected by you with your movement or voice, and those would be conversations you would have to determine potentially the placement and what would occur with that.
And I think ultimately the decision is up to you, your physician, and the neurosurgeon. They used to wait till I think the message I've heard when I've heard talks is they are starting to do the surgeries earlier than we historically used to do them. But that again is all a conversation between you and your physicians to determine if you are at that point where you're ready to consider it as an option. So,
yeah. And above all, make sure you sit down and make a list of what you're trying to address with your DBS surgery with your physician.
That's great advice. Yeah. Because how many times you sit down in the doctor's office and you had all these great things you were going to ask and they go out the window, right? You leave, you get home, and then you think, shoot, I forgot to ask this question. So that's a really great piece of advice. Write it down, write down the symptoms, write down the questions you have. So you make sure that you maximize your time in front of your doctor. Well, good. Well, I know we're beyond our time, but I really appreciate you all staying. You will be asked to take a survey after. We introduced that already at the beginning. So if that pops up, go ahead and take that survey, answer those questions, and let us know what else you might want to hear about in the future. And thank you. If any of you guys have questions that come up after the fact, just email us and we'd be happy to answer. And again, a really special thank you to Dan for being put on the spot last minute and being willing to share a little bit of his insight. I really appreciate you being willing to do that, Dan. I think that was very beneficial for our listeners. All right. Well, thanks, everyone. We look forward to joining you at another webinar in 2024. This ends our series for this year. So we'll look forward to having you join us next year. And it will be available on demand. If you missed any part of it or want to share it with others, it's usually up within 24 to 48 hours and available on our on-demand section on our website. Thanks, everyone. Have a great rest of your day.
Thank you.